Great, thank you. Just a correction, not doctor, only in my dreams, but I'm very saddened that Dr. Abashi is not able to be here today. I'm in no way able to replace him, but I have had the honor of working with him for 25 years. So I believe that I've learned a little bit from him, and it's a privilege for me to be here, and thank you very much for AARC, for Draeger, and for sponsoring us, and for all of you for being here. So I do want to talk a bit about using APRV early to prevent acute lung injury, to prevent ARDS. You know, there's a lot of controversy in this topic, in this mode, and one of the things that we talk about is actually using it to treat ARDS. Let's face it, you know, 40 years we've found nothing to actually treat ARDS. And so we have actually moved the, we're in the football season, so we've moved the chains back a bit. We want to prevent it, and there's a lot of things I think that we can do. Again, as with everything that we fully disclose, that we've lectured for ICON, for Draeger-sponsored symposia, and but again, none of the funding has influenced any of our work. I know you guys are tired. So I know you guys are in a carb crash, so hopefully I will be able to entertain you and keep you awake. So mechanical ventilation we know is required. We know we have to put people on the ventilator for various reasons, for different states of respiratory failure, but it does not come without its own problems. There are problems just with putting patients on mechanical ventilation. So the very thing that we're using to keep keep these patients going is going to cause problems. So one of the things is actually in 2004 they looked at the potential for ventilator-associated lung injury, and they showed that patients, 25% of patients who were ventilated for more than 48 hours, who had no acute lung injury at the outset, went on to develop acute lung injury. That's a huge amount. So you come in with, for whatever reason, you're put on the ventilator, 25% has the potential to develop acute lung injury. And from those patients, 60 to 80% may end up developing full-blown ARDS. Inferior gas distribution. The ventilator will not distribute the gas as we take a breath. It's just not going to replace that natural method. Ventilator-associated pneumonia, again, it's going to increase the risk. And ventilator patient asynchrony. I do not want to be put on the ventilator and told, you have to breathe this size tidal volume, this many times a minute. I mean, we're controlling the patient. They are asynchronous. They don't want that. And that's the last thing that they need. So we should come up with a new way of thinking. Now, the old philosophy is to conform the patient to the ventilator. I know what's best for you. I'm going to put you on here. I'm going to dial these in, and you're going to cooperate. And if you don't, then I'm going to sedate you. I'm going to paralyze you, and I'm still going to tie you down in case you try to get away. So let's think of something new. Let's actually try to conform the ventilator to the patient. Let's try to restore that normal method of breathing, that normal synchrony. So as Dr. Kolish alluded to over the years, that we have not really seen a big reduction in ARDS mortality. Now, there was a really big reduction here in the early 90s, but that actually coincided with the AECC definition. So we actually came up with the definition of ARDS. So we were able to coin something, and we were able to define it. So we see that first big drop. But if you look since 1992, it's really been a flat, level playing field here, which is really disturbing that, you know, the ARDS mortality rate is still roughly around 40%. And we've continued that since the year 2000. We look at, you know, the trials, the ARDSNet, the Love, Express, Alien, even the Oscar and the Oscillate, and we see that roughly the mortality is somewhere between 30 and 40%. Also in 2014, it stated that it seems the incidence of overall mortality has not changed significantly, and it still sits at 40%. To even the most recent, the SAFE trial, again, 50 countries, and we still have an ARDS mortality of 40%. Now, if you are lucky enough to actually survive ARDS, this is actually your, potential outcome. The one-year mortality for those who have survived ARDS is poor. It's so, great, you get through it, and now you survive, but your outcome is still poor. So the question is, when should you actually actually consider lung protective strategies? What's the point? And I think personally this is too late. Okay, so we actually want, we want to start and we want to prevent. And if you think about it, prevention versus treatment, again, I want to get away from treating ARDS. I don't want to talk about treating it. We do this every single day. We prevent versus treat. It's much better to put that sunscreen on when you know you're going to the beach and it's going to be beautiful out and sunny than this. Okay, this is a lot harder to treat. We can prevent. And we do this in medicine also. DVT prophylaxis, GI prophylaxis. We put patients on a bowel regimen. We do this ourselves. We try to diet, try to exercise, try to maintain our health so that we don't have to treat things. So why should this be any different? And we actually noticed this at Shock Trauma. Again, Dr. Abashi was recruited to Shock Trauma back in the early 90s to start an ECMO program. So he came in and he had this ECMO program, and he had a really difficult patient that he actually put his first patient on APRV. And what he noticed was, dramatic recruitment and able to get the patient off of ECMO. And so he started actually applying it a little bit early. Well, while they were getting ready to cannulate, let's go ahead and put these patients on APRV. And what he noticed was, wait a minute, these patients actually didn't even need ECMO. He was able to recruit the patients and get them off the ventilator without ever even going on to ECMO. So they were applied exclusively as a rescue mode in the early 90s, 92, 93. Then it was actually early application to prevent respiratory failure, and now it's basically a standard of care. So we looked, this was published in 2001, and we looked at patients that their overall incidence of ARDS, 8.5%, and a mortality of 29%. And then after the introduction of APRV, so this is this 92-93 period. Again, not demonstrating that this was exclusively a result of APRV, but it was coincidental. This was one major change that we had, was we started using APRV earlier. So we noticed a reduction, and actually in 2013 we looked at patients that had a high injury severity score. So what we did was we looked at patients comparatively. This is not a randomized controlled trial, but rather an observational meta-analysis. So we looked at like patients, and we pulled those like patients to a tune of 66,199 patients and compared those with our 231 patients. And this is the injury severity score. The average was 29, which is quite high. They had one or more femur fractures, which again, they're usually in bed. They get a lot of blood products. They have their surgeries. And chest, abdominal, and brain abbreviated injury severity score greater than 2. Also, the resuscitation in the first 24 hours, blood products, an average of 10.6 units, average of 8.6 units of FFP, and 11.5 liters of crystalloids. This is all within the first 24 hours. So what we were trying to look at is a group of patients that we believed were at high risk for ARDS. So we went one step further. This was actually published right at the time we were compiling our data, and it looked at the early indication of patients with acute lung injury and assigning them a score. So it's called the Lung Injury Prediction Score, or LIPS. So what they did was they took these predictors of acute lung injury and of ARDS, and they assigned them a point. So you go through, if your patient was in shock with a high lactate, you got a score of 2. If they had a traumatic brain injury, they got a 2. Lung contusions, 1.5, etc. So you add these numbers up, and you came up with a score. The higher the score, the higher the potential for acute lung injury and ARDS. And so this is the scale that they came up with, that if you had a low score less than 1 or 0, your risk for developing acute lung injury and ARDS was low. As the points went up, of course, if you had 8 points or greater, you had a high risk of developing acute lung injury or ARDS. And our patients scored 8.7. So again, we believe that we were studying a group of patients that were at high risk for acute lung injury and ARDS. And here were the results. The average, the mean injury severity score was 25.7, and our patients scored on average 29.7. So we were in the upper quartile. We were studying a very sick group of patients. The average mean, or the average incidence of ARDS was 14%, ours was 1.3, and the average mortality 14.1%, and ours was 3.6. So again, we looked at these patients that we actually used APRV as standard of care, not waiting till they developed ARDS, but as standard of care to prevent ARDS. And this is just an overall looking at those dates back in the early 80s, the early 90s, and up until now, 2005. And we've seen a gradual reduction both in the incidence and the mortality. And then also we compared ours to the National Trauma Database, and our incidence was significantly lower, as well as mortality with a higher injury severity score. So what's the mechanism? Now I know that Dr. Kolish, Gary went over all of the, a lot of the mechanisms, and I won't, go over a lot of those again, but we actually continue to study. The more that we look at this data, the more that we look at the science, it asks more questions. It begs to wonder why, what is really the key here? Is it magic, as Gary said, or is it just the science? And this is one of the studies. Again, a high fidelity lab. This is just like any ICU. Replace this hoof with a hand, and these are some very, very sick sick animals that we treat. And this was this is some pre-published data looking at the application of early low tidal volume strategy compared to APRV. And again, using this peritoneal sepsis and ischemia reperfusion model, as Gary went over. And this is just one thing. I know that Gary alluded to how many liters of volume that the animal received. This shows you, this is pre-surgery, okay, so this is what the animal looks like, and this is at 48 hours. So again, just showing you that these lungs should come out, wet and injured and very traumatized. But this is the, again, this is comparing late low tidal volume, early low tidal volume, and APRV. And again, APRV, the PF ratio maintained well above any acute lung injury. This line here, early low tidal volume, the trajectory is that probably a little bit longer they would have developed ARDS, but they did not quite develop full-blown ARDS, but again, the late low tidal volume did. And the FiO2, as Gary mentioned, remained on 21% throughout the entire study in the APRV group. And this is actually really interesting because we talk about these plateau pressures, the sacred level of 30, not going above this. And if you look at this, the APRV group, our plateau pressures were 30, but similarly, the driving pressures were lower or the same as the early low tidal volume group. So 6 cc's per kg, and you can see the tidal volume itself was around 10 to 12 versus the 6 cc's per kg, but the same driving pressure. And that's really important because driving pressure is probably the only thing that's really been marked as related to ventilator-induced lung injury or mortality. And if you look here that the survival in patients under protective ventilation, the driving pressure is actually what correlated the most with the mortality. And again here, just looking at tidal volume staying in that 6 cc's per kg range, and the driving pressure was lower as well. But again, this is actually looking at where's that pressure going. So when we use APRV, and Dr. Abashi's talked about this for years, he's talked about actually the chest wall creeping. And we don't want to go in and just, blast the lung open. And as Gary said, we're going to nudge it. And, as the lung recruits and it just keeps nudging and pushing the chest wall open and it creeps. And these are just, again, some of the biomarkers from that study. The plasma IL-6 levels remained low in both groups, in the APRV group and the early low tidal volume. But if you look at the bronchial alveolar lavage, so the IL-6 in the lung, the late low tidal volume had the highest, early was the next, and APRV was very close to the naive or the control group. And this is also surfactant protein A. APRV was able to also preserve the surfactant the same as the control group. And here's just a general picture of looking again at the late low tidal volume versus the early low tidal volume versus APRV. No edema in the airways, nice and homogeneous. And so just to touch a little bit on macro versus micro ventilation, and this is what we've been talking about, is actually looking at the ventilator, looking at what tidal volumes generated, looking at the numbers at the ventilator versus what's happening at the alveolus. Now, of course, you can't go in and you can't, open your patient up and peek at the alveoli, but that's what we need to do. We need to get at the alveolar level and see what's going on. And this is one of the, Okay, and this is the normal alveolus, and again, if you look, there's very little change. It's very stable. You can hardly see anything moving, and then when you have injury, there's a lot of opening and closing. And this is one of the problems, is that we still continue to teach today this whole grape theory or the alveoli as balloons. They're not balloons. As Gary said, they share walls. They are affected by their neighbor, and it is definitely in accordance of how the lung is distributed. So there's a lot more than just grapes. There's all these shared walls, and it's a very complex system. So also in looking again, what you see at the ventilator, so if I dial in that 6 cc's per kg versus, what I get from APRV, and everybody's horrified at these tidal volumes, you have to look at what's actually going on. And this is actually a study that they showed tidal hyperinflation with low tidal volume. So if you look here, here's a patient with a little bit of collapse down here, and you can see this is the blue area is the lung that's open, the green is collapse, and this is at inspiration and expiration. Now you can see as the amount of collapse increases in the bases of the lungs, the red is the hyperinflated areas. So even with low tidal volume strategy, you can still tidally hyperinflate. And this is interesting. This is electrical impedance tomography, EIT. It's not currently available in the U.S., but we can use it to study on animals. But what we did was we applied this to the animal during the study, and a belt goes around the chest, and you look at, here's the measurement of the air that's in the lungs, okay? So you can see you divide it into 4 quadrants, and these 4 quadrants will add up to be a total of 100%. And so you can see that this is pretty regionally distributed. Everything looks pretty good. Now this is a low tidal volume strategy, so we did 6 cc's per kg, and you'll see after about 12 hours where is the 6 cc's being distributed. At the beginning, it's very evenly distributed, but after about 12 hours, look at what happens. The entire 6 cc's per kg is right here. So this low tidal volume strategy to protect the lung is being driven into one little quadrant. And I think you've seen this before, but this is also what it would look like in the lung. So you can see all the volume is going mostly into that area of compliance, while the rest is being ignored. And versus when you have a nice distributed lung, here's APRV, and you can see it's fully recruited, and so it's very homogeneous, and again, the alveoli follow the same pattern. So the mechanical breath profile, and this is what we're really talking about also, and I'll go over this in the next talk, but what are we looking at? You have to make sure exactly the mode that you're looking at. Are you really looking at APRV? And APRV uses the same ingredients as anything else. It's not, mysterious. We don't add anything different. Pressure, flow, volume. They're the same ingredients. But it's how you apply that. It's what dose you use or what ingredient you use and how you apply that. And so here's the ingredients. I gave a lecture in Australia, and this is a dessert called pavlova. So you take your ingredients, you assemble your ingredients, and then you follow your directions. Same with APRV, same with a protocol. So you have your ingredients, which is your P high, your P low, your T high, your T low, and then you assign a number to that, and then you apply that. So if we take all of our ingredients and we follow this and to the letter, then we have a very nice looking dessert and everything looks pretty good. But if I'm going to change things a little bit and I want to try to maybe make it, I don't like that P high of that, and a P low of 0 really makes me uncomfortable, so I'm going to add a P low, and I'm going to change the T high and cut it down a little bit, and I'm not buying into that whole 75%, so I'm going to change that a little bit. It's the same as cutting corners in an ingredient. So I'm going to, instead of 4 eggs, I'm going to have 2. I'm going to skip the cornstarch because I'm out of it, and I'm going to hurry up the directions a little bit, and then this is my result. So now I have to consider what was wrong. Was it the recipe or was it the controller of the recipe, right? So the recipe's there. So the reason that I point that out is my question to you is this APRV? It says bilevel on the ventilator. It says bivent or APRV biphasic on the ventilator. It means it has to be APRV. Well, if you look a little bit closer, this one is 2-to-1 pressure control. You have a pressure of 18, a PEEP of 5, and a rate of 8. That's pressure control 2-to-1. On this one, I have APRV biphasic. I have a T high of 1.5 seconds. So again, you have to look at what you're setting. This is another one here, and I actually have some studies where this is pretty much the settings that they were using, and they're calling it APRV. This is a 1-to-1 IDE ratio. I've got a rate of 32, a P high of 36, a P low of 22. So is that APRV? But you know what? It's going to be written on the flow sheets. It's going to be written in the chart. It's going to be published in a study. So this is actually the waveform. This is the mechanical breath profile of what we've established with Dr. Abashi. This is what he's done over the years, is to develop this. Of course, Dr. Downs invented it, but actually Dr. Downs came and gave grand rounds at our hospital one time, and he said, I may have invented this mode, but Dr. Abashi has perfected it. So it is, it is something that he has painstakingly stayed at the bedside to look at how, the patient responds to this. So if you look at it, it really does follow the CPAP with a release. And also, just to go back again with the driving pressures, people, the driving pressures are very, very high in APRV because you're going from 25 to 0. You're really not going to fall off that cliff that fast. So remember, that pressure is not going to go from 25 to 0 in 0.5 seconds. It's just not going to happen unless you have something, actually taking that gas out. So Gary went over this. I'll just hit this just a little bit again. Is time the missing component? And remember, the alveolar pressure and the alveolar pressure and what the pressure from the ventilator, they have to intersect at some point. And it's not going to happen at that 1 second cycle time that we see with our conventional ventilation. This is 40 seconds. You saw how the lung unwrinkles and how it opens, and that's why we compared and looked at what's going to happen over that time course. And this just shows you, this is actually looking at alveoli, and you can see how this alveoli opens over time and shares its dependency with its neighbor there. And again, this is something you've seen several times now, the actually adjusting for end expiratory lung volume using time rather than pressure, because time is much more precise. You can capture the fastest closing time constant by adjusting time rather than adding pressure, because I don't know which alveolus needs 5 centimeters, which needs 10, which needs 15, which needs 0, but adjusting the time can account for those time constants. And again, this was an abstract that we did looking at the time during CPAP or during APRV, that CPAP phase, and then the time during the release phase, and adjusting that T low to capture 10%, 25, 50, and 75%. And I'll stop there and actually just go right into the next talk.